Okay. All right. I have the top of the hour, so we're going to go ahead and get started. Thank you all for joining today. It is always a pleasure when we see familiar people jumping on month after month and learning along with us at our Hope Cultural Training Series. My name is Cynthia Bell, and we have several special guests that I'm going to allow Beth to introduce. So I just am super excited that you're joining us today. So just to kick us off, I have to read this kind of acknowledgement and disclaimer for PCORI, but while I'm doing that, just listen and then type into the chat your favorite fall activity. I love when we can connect with each other and just find out a little bit more about what you look forward to in the fall. One of my favorite things is hiking. This is a trail close to my house, actually. So this is a training series funded through Patient-Centered Outcomes Research, or PCORI. Our engagement award is 34437, and the views and statements and opinions are presented in this cultural series are solely the responsibility of the authors and do not necessarily represent the views of the Patient-Centered Outcomes Research Institute, its Board of Governors, or Methodology Committee. The other thing that we like to point out is that we do need your support. And so Catherine will be dropping into the chat. Catherine's one of our leaders with the Hope Cultural Training. She'll be dropping into the chat a pre and then a post evaluation. And this is important for us to be able to show our funders how you are learning through this series. And it's a great way for us to see what also we need to maybe revisit, which we will be kind of tying some of those things into our November and December series. The second thing that we would like your help with is for you to join us. And this is open to Native Americans as well as non-Native Americans who are learning. But PCORI really wants everyone to be able to come to the table and be knowledgeable about research in the event that any of you want to partner with Intertribal Council of Michigan or any of the tribes to actually push forward their agenda. And so that kind of training and discussion will occur in November and December, this same place, and we'll tag that on to the invite. So you'll get that for November and December. So we look forward to seeing your faces again in the next couple of months. That brings us to our introductions, and I'd like to introduce to you my friend Beth Seeloff. I'm very, very fortunate to be working with her and partnering, and she is the reason why we were able to connect and kick this off. Um, Unfortunately, Beth is retiring, so those of you who might not know, I should have asked her if I could publicly say that, but we're just so happy for her, and she's not going anywhere. She's still very invested in the community, but she is officially setting sails to do some fun things outside of work. So we're thankful for that. We're thankful for her. The disclosures are listed on the screen along with our speakers. This is also something that we have to make sure that we share with you. And then if you would like CME credits, text 65983 to the number on the screen. And I'll drop that into the chat as well. And I am going to stop sharing and turn it over to Beth.
Thank you, Dr. Bell. Good afternoon, everyone. And again, this cultural training is going to discuss how we can foster understanding and respect in a health care center and also in a community. I'd like to introduce you to our panelists today. We have Kelly Hansen, and I'm just following my screen around in the circle here. We have Kelly Hansen, who is a health educator at the Hannahville Indian Community, just northwest of Escanaba. I lose my directions when I get over that far. Kelly is also bringing in a special aspect because she too has endured the challenges of cancer, and we're going to get her insight on that today. We also have Laura Fisher, who not only is the director of health education and chronic disease at the Intertribal Council of Michigan, but she also brings innate experience as a caregiver for family members who are walking that journey with cancer. And then we are very pleased to have Dr. Sofina Calderon, who is Chief Medical Officer at the Keweenaw Bay Indian Community and the Keweenaw Bay Indian Community Health System, and Dr. Frank Ananikwam, who is the Medical Director at the Little Traverse Bay Bands of Odawa Indians in Petoskey, Michigan, and Dr. Calderon is located in Baraga, Michigan. So we have a very diverse, very important rural view of the challenges individuals face in a healthcare setting that is not in a metropolitan area across Michigan. My first question I'd like to ask Laura, do you mind introducing yourself?
Yeah, bonjour everybody. Wawash Keshikwe, Nijnakas, Makwa Dodam, Bawating and Donjaba. My name is Laura Fisher, and I'm the Director of Health Education and Chronic Disease, as Beth was saying, and I'm a member of the Sault Ste. Marie Tribe of Chippewa Indians. Um, and I'm here representing family member, caretaker, as I've helped navigate the processes of quite a few of my family members, but most closely as my mother.
Thank you, Laura, and we appreciate your mom too. Dr. Calderon.
Hi, yeah, she Sofina Calderon Yinche, ki ani nishle do look at the net bashichin, a she dashe do Habaha Dashanala, Akuta, the Ned Stanishle. Hi, I'm Sofina Calderon. I am from the Navajo Nation. I came up to the UP about 3 years ago and currently serve as the Chief Medical Officer for the Keweenaw Bay Indian community up here in Baraga. And just providing a perspective of providing care for our relatives in our native nations, both back home where I served previously for 10 years before coming here, and currently seeing patients, in addition to some of the administrative work that I do to help modify and manage care for our relatives seeking out care in our health systems.
Thank you, Dr. Calderon. Kelly.
Hi, my name is Kelly Hansen. I'm the health educator here at the Hannahville Indian Community. I've been in this position for about 8 years now. I also am a cancer survivor. Back in 2021, I was diagnosed with triple negative breast cancer. So that has really helped me with our patients' navigation as they go through cancer diagnoses here in Hannahville.
Thank you, Kelly. And Dr. Ananikwam.
Ani buju azal banesh desnikas waganak sing odaw and Indian Dow mikazay dodem azal mamishkik in Indian Dow and on my way to going to Benda Dagwas. So my name is Frank Anamikwam. My Anishinaabe name is Yellow Thunderbird, and I'm a citizen of the Little Traverse Bay Band of Odawa Indians, of which I'm our medical director for our tribe clinic. And my clan is the Thunder Clan. In our tribe, our traditional name is the Odawa from the place of the crooked trees. And so I wanted to acknowledge that too with my introduction. And my family's village is Cross Village. If any of you have had the chance to go there, it's a really beautiful place. And similar to Dr. Calderon, I see patients as well as balancing my time with administrative responsibilities and duties. And it certainly adds to a challenge of providing practice and care, and look forward to sharing with everyone, some of my experiences working for our tribe as well as in a rural setting. Miigwech. Thank you.
Thank you, Dr. Ananikwam. Laura, I was wondering if you could talk a little bit about your journey with your mom and the challenges and successes you had with your community or with regional or statewide health systems on that journey?
Yeah, I feel like I could talk really long time, exceed our allotted time frame. So I'll try to keep it really brief and like raise your hand or something, Beth, if I talk too long. Um, yeah, so my mom was diagnosed a long time ago and she had a couple. So she was diagnosed with stage 4 breast cancer. And at that time, actually, it was 15 plus years ago. And she was very fortunate because our tribal community, Sioux Tribe, had a patient navigator on staff, actually contracted through Intertribal Council. I think it was one of the first programs that they had. And as she was diagnosed, she was fortunate that she had a patient navigator right from the start. And it was instrumental in her success with going through her cancer treatment. So um, they provided her with a book to write down everything, to put all of her paperwork. And without that, I don't think that my mom would have been as successful because it was really overwhelming to her. Um, First off, as we know in Native communities, there's a lot of trust issues. And my mom was one of those individuals who really disliked going to the doctors and really put off a lot of her appointments until this happened. Um, my family is a little bit different than many families when it comes to Indian country because my mom was fortunate that all of her children decided to go towards the health field, and then my dad also was the clinic manager. So all those pieces are like very positive pieces in her life that many people don't have access to the way she did, with paying attention to all the processes that you can go through, all of the programs that are available, and attending. So we attended all of her medical appointments with her because a lot of times in our rural communities, there's a lot of delays when it comes to um, getting your mammogram, finding out your where you're at, if there is a spot, getting a referral, the referral system to get a biopsy, and then making the choices. So those processes, I'm going to say, were always one of the big areas, the barriers in my mom's care throughout time, from the time that she was diagnosed up until the time she passed, because throughout that time, there was many different pieces. So you'd go get lab tests at your local um, tribal health system, and sometimes those lab tests wouldn't arrive to where they needed to go in time. And that's just across the board in rural communities, and getting in managing our tribal health systems to match the bigger health systems across the state. And the first time my mom was diagnosed, she was very fortunate. We had an oncologist up here located in Sault Ste. Marie who was very supportive of traditional medicine and told my mom, make sure you're utilizing your cultural ways just as much as you're utilizing what I am providing for you, because that is where I find the most success rate. Um, Throughout time, we had a lot of complications in my mom's care through her chemo and radiation. Then it shut down her kidneys and liver, and she had a kidney and liver transplant, um, which made her care a little bit um, more difficult to navigate. And many people up here were then very nervous about handling her case. So she was transferred down to University of Michigan, where she received her transplants. But after that, when her cancer returned, she did not have that same support as she did when she was first diagnosed with the oncologist up in the area. And they told her to stay away from her cultural ways and traditional medicines. And so we've had across the board a lot of different successes that other people were not privy to and didn't have access to, but also there were still many of those gaps. Another one of the big gaps is the weather. We are located in Sault Ste. Marie, so all of my conversation right now is coming from Sault Ste. Marie, Michigan. Everybody on this call is kind of coming from a different location, which is also going to add a different perspective. But radiation treatment is you can either head across 3 hours to Marquette area or even further at that time when my mom was receiving treatment, which every day you're going for radiation, or you can take a bus that they had coming from our local hospital here, cross the Mackinac Bridge, and go down to Petoskey, Michigan, which, as if people are really know a lot of information about our Mackinac Bridge, we have certain times of the year that the bridge is shut down for days at a time, which also causes a lot of different stresses in many people's lives, especially going through treatments where you need to have it every day. And that's the only way to access it. So you're heading down But on the positive side of that, those buses that they provide transportation from the patients up here in Sault Ste. Marie down, it was kind of like a little support system in itself because um, my mom always talked about her friends and they stayed in contact through the entire time of um, her cancer treatment. Um, through her battles and through their battles. So it became like its own little support system in itself of all of the people on their bus that were going through different cancer treatments and on the bus for radiology. But those are some of the main barriers and issues that we had. Uh, Another one that I think is really important is the family support system. My mom came from a non-medical background, and so she was just really overwhelmed every time she heard of conversations. You'd ask her if she ever went to a medical appointment by herself. You would ask her what they had to say, and she'd be like, I don't know. I'm okay. And so we always had to make a very cognizant effort to have one of us attend each one of her appointments with her so that we could come back and pass the information along. If my dad was unable to be there, my brother or myself was made sure that we were there so that we could navigate whatever they were telling her at the time, because in her eyes, it was all just like big words and overwhelming, and she just shut down. So I feel like those are the main pieces that I want to share. Um, I feel like I could
Thank
go
you,
into
Laura.
more detail, but I'll leave it there for now.
Thank you. Kelly, um, could you share what some of the biggest barriers you faced in getting diagnosed and treated and supported?
Sure. So, my journey started back in 2021. I was just 34 years old. I had a 1-year-old and a 2-year-old at home. Um, so I found a lump, and that's how I got to the doctor to have a mammogram done. And once I found out it was cancer, it was 2 days before Christmas. So at where we are at, we don't even have our own oncology system. We have a satellite treatment center from Green Bay Oncology. So there were no oncologists on, there was nobody was around. So what I did is I actually reached out to Beth, and we got in with Corewell, and I drove down to Grand Rapids 2 days after Christmas to see what was going on and what they recommended my treatment be. And luckily it ended up being the same exact treatment that the oncologist here up in Escanaba had suggested as well after I got in and seen them. So it was nice to have that reassurance that both oncologists agreed that this was the best treatment for the type of cancer I had. So other than that, like the location, just being in the UP, we don't have access to the biggest cancer centers. And like I said, I was treated at a satellite center through Green Bay Oncology. When I needed to go to the breast surgeon, I had to travel 2 hours to go to Green Bay for that. And then also to a big part of our treatment center here in Escanaba, where all of our patients go here at Hannahville when they're diagnosed and they need chemotherapy. They go to the same satellite center that I was at. And the privacy there is not great. You don't have your own separate room. You are sitting next to someone who is receiving treatment right next to you, and you're just divided by a curtain. So there were times where I was in there, and if anyone has ever gone to chemotherapy with a loved one or anything, it's a process. You're there for most of the day. So I mean, I would be there and I'm trying to deal with my own thoughts and my own issues that I'm dealing with. And I can hear people crying with their family next to me because the news they just received when they went in to get their labs before they came and got their chemo was not good news. So just that privacy piece was a huge barrier for me. Luckily, since then, we have now built a new cancer center here in Escanaba at OSF, and the rooms are private. So luckily now our patients can have a private room when they're getting their infusions. But mostly it just location was a huge barrier. And just another thing was too, is just making sure the oncologists were there the days that I had my chemo. But I kind of right, being in healthcare and working with cancer patients already through my position, I was a pretty good advocate for myself. So I asked, when are the oncologists in? Well, they're here Mondays and Thursdays. Okay, well, I want my treatment either Monday during the week or Thursday during the week because I want to make sure one of them is in case I have questions. Otherwise, it's a nurse practitioner or the nurses that are administering the chemo and there to answer questions on those other days of the week. So but mostly, yeah, just location was a huge barrier, and then the privacy piece was not great.
Thank you, Kelly. Can you tell us just a little bit how your experiences have differed from patients who have been diagnosed or treated for cancer in your that you serve within the Hannahville Health System?
Yeah, so hearing that you have cancer is a huge, obviously, I can't even explain it. It's just like kind of everything just drowns out, and all you can put, you're in survival mode. So you're no longer living, you're just trying to survive and get through that. And so with me, luckily, I had a good support system. I had an education that and a background that helped me, like I said, advocate for myself. I had a husband who was working, who could pay for our bills when I wasn't working. Just I had a lot of support. So here I've noticed with some of my patients that I've met, so not only are they dealing with his cancer diagnosis now, they're dealing with four other issues. One of my women was going through addiction during the same time that she was diagnosed with breast cancer. So now she's trying to get addiction treatment at the same time that she has to go receive chemotherapy. I've talked to patients that have, they'll tell me, they'll say, well, I can't go to treatment this week. And I'll say, well, why can't you go to treatment this week? They say, because I have to watch my grandkids. Like I have no one to watch my grandkids. And they have bills to pay, right? Well, I have to work because I have to pay for my electricity and I have to feed everybody. And just all these other worries that some people don't have to think about when they have the biggest piece that they're doing is trying to survive. And then they have all these other things, factors that are just dumped on top of them as well. I had a woman come in, and this was after we were actually going through breast cancer treatment around the same time. And she looked at me and she asked me, and she said, well, how do you still have breasts? And I said, because I had reconstructive surgery. She was never told that was an option. So she's flat, she was constructed back flat, and she was never told about these reconstruction options for her. So there's a big disconnect. There's a lot of areas where we can do better and just making sure that care and treatment is uniform across all walks of life.
Kelly, thank you for bringing up the um, subject of equity. Dr. Calderon, if you could design one solution to reduce cancer survivorship disparities in rural tribal communities, what would it be? Like, what do you think about for the men and women in your community?
Yeah, I think improving communication between a patient's primary care provider and their oncologist or subspecialized teams. When we work in native healthcare, we spend a significant amount of energy and time in getting to know our patients prior to cancer diagnosis. And hopefully, you've already developed a relationship with your patient at the time of diagnosis that then kind of helps you to provide all those options for your patient. And, when they go to their subspecialist appointments and see their oncologist and hear all their options and, whether that's treatment options or other, post chemo or reconstructive options, as Kelly had mentioned, we can kind of communicate better about that between our primary care providers, whom our patients tend to trust, and be able to provide all those options again in a follow-up visit. I have plenty of patients that, who go to see their oncologist and they come back to visits with me and, they ask, hey, I saw my oncologist, but I don't remember what they had talked about. And they mentioned I had all these options, but I don't really understand what those are. And so being able to, have that continuity and that communication well established between the primary provider whom the patient trusts and the subspecialists or the oncologist. And then just being able to sort of re-explain all those options, in that setting where I've already developed a good communication pathway with my patient and have their trust in terms of helping to navigate their options. And not a lot of patients, as Kelly had alluded to, understand very well what all their options are and don't fully take advantage of, not just pre-cancer diagnosis with cancer screening, but also, treatment adherence can be affected. There's multiple things that can contribute to, treatment adherence or not being able to follow through with all of the recommended guidelines that are out there, but also even access to participation in clinical trials. We always think that out here in Indian country, we're isolated. We don't have access to all those options. And a lot of patients have, grown up in a tribal healthcare system with tons of limitations and don't exactly believe that, well, oh, I could never get that or have access to that because I go to IHS, and there's just, myself having grown up in a family with an extensive cancer history as well, just like Laura had mentioned with her family, being able to take your parents and grandparents to their oncology visits and helping them to navigate, that care to then find out, oh, we do have options. We in Indian country have pathways or ways to be able to get the care that everyone else has access to. But navigating that is really, really difficult. But there's just that assumption among a lot of our patients in Indian country that, oh, that's just something that they can get only in the city, and we can't get that out here, from IHS. And so I really like to, break down those barriers when I have those discussions with my patient to kind of say, okay, well, these are all your options. Well, whatever you feel like you can, whatever feel like it'll best fit your comfort and your level. We'll be able to put that plan together for you and be able to follow through with that. And it's nice in the tribal healthcare setting in, a 638 umbrella setting to kind of be able to get what your patients need and not have a lot of the rigid barriers that tend to exist in other healthcare settings in Indian country. And that's one of the great benefits I love about being able to sit in a position within administration to make changes and improvements and be able to get what my patients need.
Thank you, Dr. Calderon. Dr. Ananico, I'm going to ask you this same question because you are actually pretty close to McLaren Carmanos, correct? Like not even a mile down the road. Um, do you see these survivorship disparities in your community, even though you're so close to Carmanos?
Yes, thank you for the question. And I'm going to have some overlap with my answer with what Dr. Calderon has shared. And we do see the similar disparities, even though we have a local cancer center in our town. I just want to take a step back, just for context. If we're looking at trying to find a solution, the challenge is very complex, right? There's multiple levels to this. You think about boarding schools, reservations, there's varying levels of poverty in our communities. And then also, historical and current inequities and injustices. And so, how do we tackle and combat all that in the healthcare setting? I think that's where it's going to call for integration of care and services. It's going to call for, further partnerships. And that's the way to really share in the lift in addressing this. What Kelly and Laura have also shared from their perspectives, geographic distances being a huge issue. I think it was touched upon, but I'll explicitly state it: staff shortages. There's a shortage of oncology services. There's a shortage of primary care services as well. Our tribal clinics, face varying levels of staff shortages that we're always trying to shore up those services. Not every tribe has a patient health navigator, which can make a world of difference in a busy clinic while we're trying to help our patients manage, a multitude of other concerns and conditions. IT and internet are also huge. There was an outage at our local Carmanos McLaren end of last year, beginning or middle of last year, and that outage on their end for their radiology software lasted a week. And we're talking about, patients who have cancer receiving those PET scans and needing, urgent CT scans and things like that. And one of our patients here were impacted by that. They had a delay in imaging and a delay in read. And so, we're trying to think of how can we get our patients the best care timely. That IT and internet is another huge factor. And then, if we're going to bring it back full circle and look at, receiving care from the Tribe Clinic or even at McLaren, Munson, Corewell, U of M, we got to make sure that care is culturally adapted and that, it's also trauma informed. And then we can also be able to meet the patients where they're at. And it's starting from the very foundation, right? If we have a Native patient coming to our Tribe Clinic, or we have a patient going to Corewell, for example, we need to start by listening to patients, listening to families, listening to communities to better know and understand their needs. And then it starts from there. And I think this Hope PCORI project is an example of that. We're doing essentially a very deep dive needs assessment. Where are the needs and how, where can we potentially meet them? And that's where we become creative when we break out into work sessions moving forward to try to pull all those other pieces in there, right, to mitigate all those barriers. I think it was Kelly shared that in her community, they built a cancer center in town. So I think that's a big lesson for many of these large health systems, bringing the care to the patients, bringing the care to the families. That's also needed. I know a very long-winded, detailed answer, but that's just my response and my thoughts on that. To speak specifically, I shared the one example of having Carmanos in town where we had an IT delay. We've had mixed experiences with Carmanos in town for our tribe clinic, and overall good. I don't want to give the impression that it's been a negative experience. We're very grateful to have Carmanos in town. I think the challenge is each oncologist is different. So I had one oncologist that was calling me. They were actually calling me to get more information about a patient that we had sent over to them. We've had conversations, and then they left. They were there for a year or two, and then they left. And so we didn't have the continuity of that oncologist. The other oncologists there, they don't reach out as much. I know they have busy clinics. Like Sofina was sharing, having integrated multidisciplinary team meetings. We do not meet regularly with oncologists to discuss shared patients. For example, like with behavioral health in-house, we meet regularly with our behavioral health team and psychiatrists in the mental health, behavioral health realm, weekly touch-based meetings on shared patients. We don't have anything like that in terms of a model with primary care and oncology. So that could be something worth exploring.
Thank you, Dr. Ann-Nicola. Kelly, can you talk about what role does trust or mistrust of the healthcare system play in seeking timely cancer care?
Sure. So, we work with a majority of our patients are tribal, and it takes a long time for our patients to trust us with their care. We were lucky enough to have a doctor here for 27 years, Dr. Greenfield. She was amazing. She knew family histories. So when they would come in, she knew, oh, well, your dad had polyps in his early 40s. So you're not, you can't do Cologuard. We're going to send you in for a colonoscopy. She just was really, really one of like a wonderful resource for our clinic. So we're actually right now in the process of dealing with those trust issues. We're trying to hire on a new primary care provider here for our clinic. Luckily, we have a PA here in staff in-house that's been with us for a long time as well. So our patients are still trust Brandy and are liking seeing her, but there is definitely a big barrier there. And I will say too, even with doing patient navigation, I have gained so much trust with our patients after they knew that I went through cancer treatment and knew that I went to the same clinic they did for their treatment. And that has really, really helped. Not just them, but it's helped me too, because before I had, we all have sympathy for our patients but I can really I know what they're going through. I know their worries, I know their fears. And so just helping them through that too. But mostly it's just having staff that stick around and that stay and they know that they can trust the people here at their local clinic.
Thank you, Kelly. Before we get to questions from our audience, Dr. Calderon, how do you approach providing care that is both evidence-based and culturally responsive?
Yeah, I think having working on our patient and provider relationships so that they are, of what Kelly had mentioned, providing that trust between patients and their providers, and making sure that providers are working on, their interactions are of trust building interactions, and just making sure that they are incorporating, doing empathic listening, incorporating a lot of values and goals of their patients into their interactions, and just really being understanding of that really helps to, provide that culturally responsive approach. And having providers that put some time and effort into getting to know the backgrounds of the communities they serve, being involved with the clinic in terms of developing the goals and understanding what your community wants out of their healthcare, and um, keeping up with evidence that's out there, that your screening evidence, and understanding and having that communication, as I mentioned earlier, with your oncologist, that, if the provider themselves has full understanding of all the options that are out there, that can help guide your communication and your discussions with your patients, to ensure that they're understanding fully what all their options are, so they're not missing out on something or left to feel that that we're holding something back. And if there's something better out there and that's an option that's accessible to them, making sure that we're very clear about that. And then making sure that healthcare systems and those in at the administrative level are really listening to their providers as well. We see our patients every day, and we are the ones that develop those relationships with our patients and have sort of an overview and understanding of what we want for our patients, and making sure that administration gets that feedback from their providers that are seeing the patients, to incorporate that in there. And really being able to, not only and just really working on rebuilding trust with the community in general, between the communities and the patients with their healthcare systems, acknowledging that, there are disparities and there's discrimination that still exists out there with, a lot of the health related and sociodemographic and systemic structural things that exist out there that are still needing a lot of work. So not only acknowledging those that exist out there, but also acting on it, making some changes that would benefit your patients to continue to seek out care, modifying your health system to make it a place that your community and your patients want to keep coming back to, not just a referral throughput and, utilizing your PRC dollars to send them off on their way, and, letting someone else take care of it. But, take it upon yourself to take care of your patients for yourself, and ensuring that your whole clinic and the staff are, are built up and in a committed way to provide good quality care for the community in general. And those are sort of the avenues I've taken to really help modify the care that we give here in our KBIC clinic. Just making it a place that the community can be proud of. And then that's, builds a lot of trust and, just to ensure that what they're getting here is good quality care and that we are incorporating the best evidence and making sure our staff are up to date with, guidelines and such that are out there.
Thank you, Dr. Calderon. On the subject of PRC or purchase referred care, Dr. Frank, could you tell us your thoughts on how regional health systems and community organizations, state partners, could opportunities to work together to close the gap in these cancer disparities or close the gap in lapses in care? And
So I think from a purchase referred care perspective, for those who might not be familiar with purchase referred care, that is a portion of the Indian Health Service dollars that are allotted to each of the tribes. And I believe the Urban Indian Center in Detroit, American Indian Health and Family Services, also gets a PRC dollar amount, being an IHS partnering or designated clinic. And so that's what PRC is and so the way it works is when a patient comes to the tribe clinic, if they're a tribe citizen of the tribe that they're going to for care, they can access those portions of that clinic's PRC dollars. Now, say they're from a neighboring tribe clinic and they come to your tribe clinic, they have to contact their tribe to potentially access PRC dollars. So there's also another thing called service area. And so if you are outside of your service area, many tribes have rules or guidelines that they need to follow in order to receive those federal funds. They cannot provide service coverage if a tribe citizen is outside of their service area. And so say someone from Sault Ste. Marie comes to Little Traverse and they're receiving care, we can cover their care for what's provided in-house for point of care service. We could still do the referrals and lab imaging and orders and things like that. But getting it covered is the other question. So a lot of times we'll connect them with their tribe's PRC to see if then they can get that level of coverage. A lot of times we may pause what we're doing for workup if they can't afford it. And so the other thing with PRC is it's a supplemental coverage. So if a patient has Medicare, Medicaid, or a commercial payer, that insurance company gets billed first, and then PRC is a backup. For a tribe citizen who does not have any insurance, PRC can be considered to cover 100% of their care. So I hope that helps
yeah,
our listeners with understanding PRC. So then you think about that, right? If someone's outside of their service area trying to get workup for cancer, that's going to create a challenge, right? And then that was the one bullet point I mentioned here is like cost and coverage for workup and even cancer treatment once it's diagnosed. And not to mention coverage for transportation to travel hours and hours one way to get care and then go back home. And so not every tribe has a robust transportation service. And even our local, like Carmanos or even McLaren, a lot of times when patients get discharged from the hospital, they say, well, your tribe will cover these, community resources. They'll have a transportation will come pick you up. We don't. We have transportation that can help with, outpatient visits, not discharge from hospital transport. And so, yeah, that's one thing where PRC is beneficial, but it also has some challenges. There was one thing we're kind of floating with our tribe medical directors, and Dr. Calderon's a part of that group. Could we look at potentially going to IHS and say, can't each of our tribe have a statewide service area that we all kind of just share? Because then that way you're looking at from a cost perspective, you're mitigating that barrier, right? You're making that barrier go away. Then it's just the geographic and service related issues you have to work with. I think partnerships are a key, establishing partnerships with local health systems, regional health systems, statewide appointed health systems. And that way we can close the gap because, once everyone gets an idea of who can capture the patient in that service area, I think we'll get less of those gaps. And I say this respectfully to a lot of all of our health systems. I think working towards collaboration and partnership versus competition can also be a way that we help close gaps. If someone is, needing care, we should have that be the priority and focus. Versus if, say this large health system is going to take on the lead of oncology versus this one and, kind of a competition for patients. So that's my answer. I hope I answered your question.
Yes, thank you.
Thank you.
Um, on the subject of being referred for care, and on the subject of equity, and on the subject of transportation, and before we get questions from the audience, I just have a quick question for Laura and Kelly. Yes or no? So, did you travel far for care? Like Kelly and Laura, did your mom travel far for care?
I traveled for my first appointment down to Grand Rapids, which was far for care. That was almost 6 hours from home. After that, I chose to have my treatment done at home,
Okay.
close to home.
And then Laura, your mom lived in Sault Ste. Marie,
Yes.
and
So,
then her care was
so originally we were able to get the chemo local here, but radiation was downstate. The
when you
second
say downstate, how far?
it was in Petoskey. That is like with traffic, 2 hours. They'd have to
Okay.
wait for 2 hours difference. Crossing the Mackinac Bridge. I was like gonna throw the Mackinac Bridge in there because that's like a barrier.
That's a barrier.
It is. Um,
And then and
and
then
then the
where?
second time around, it was University of Michigan, so over a 5 hour drive back and forth the entire time, multiple times a week.
Okay. And I'm sure that happens to patients, not just American Indian and Alaska Native patients served by our tribal health systems, but rural patients across Michigan. And then this is yes or no. Did anybody ask you your zip code when you arrived for your care and how far you traveled?
No.
No. Laura? No.
No.
Okay. With that in mind, I'd love to take questions or comments from our wonderful participants. If you have anything, you can put it in the chat or just please feel free to unmute yourself.
I think before any questions roll in, Beth, could I add on an additional comment?
Yes, please.
Typically one of the things that I do when I sort of get ready for, panels or speaking, I kind of do a quick literature search for certain terms and certain things. And one of the things that I was sort of, reading up on when I was kind of looking into this topic a bit more deeply was just, the scarcity of data that's out there. And I just wanted to kind of mention that as well for our Native relatives, across the U.S. and elsewhere. There just is not much data that's out there for Native populations collected with respect to cancer care. There's a lot of qualitative research that exists about patients and their trust in the medical system. And, whether that's developing tools for measuring how much a patient would trust or distrust the care that they're getting. But, when they did a lot of the research that exists out there, there's very, very little and what was interesting was that there was a couple of studies out there that looked at the comparison of how much our Native communities had trusted the healthcare systems when they were seeking out cancer care. There was only just a very few uh, citations that have popped up when I was kind of looking into all these studies that just mentioned, well, the medical mistrust is, there despite interventions that many people do for Native communities. It'll increase and improve patient experience and patient satisfaction, but not necessarily change the amount of trust that a Native patient might have in their healthcare system and where they seek out their cancer services. So, I thought that was an interesting thing, and just, that I mean, in terms of seeking out more data and more information so that we can help our patients to, when we take a look at the data that exists out there, there's not much that exists for Native populations.
Thank you. And honestly, Dr. Calderon, a big part of the Corey Hope Project is to inspire individuals to do more research and more studies and get this information out there for providers across the US. We hope to share everything we learn, and like we're recording conversations like this so that they can be archived and people can learn from them. While we're looking at questions, if anyone has a question, we do have another poll, and you know how important those are for evaluation. So while we're taking questions, please feel free to unmute yourself as you're answering the poll questions. And I know a lot of you
I
out
can go
there.
ahead and ask a
Okay.
question. Thank you so much to each of you for what you provided and gifted us with this knowledge. And as Dr. Calderon was talking, I was thinking about like that, that is the purpose of this group. And there are a lot of people on this call that are very eager to build trust, but like, what would your recommendation be in terms of, I know there's a trust issue on actually being a participant in a research study. So does it start before that? Like, does it start with, what are those things that we can do and how do we gain access to tribes that need our support? That's perhaps a non-research thing. Like, what are your ideas for that, I guess? In addition to research, because I'm a researcher, I would love to do some quantitative studies or qualitative studies, but like that in itself is a process um, of building that relationship. So anyone can answer on the panel.
So the one thought that came to mind, community engaged research is probably the best approach right now. I think it, randomized controlled trials might be a little more cold. And I think with this PCORI Hope research project we have going, I think is an example of community engaged research. And it helps to have those community connects, those tribe connects, because we have a level of established trust, and I think understanding and respect between with our tribe citizens. So it helps to bring kind of outside partners in. So that's my thought on that.
Yeah, I think echoing what Dr. Namaquan has said, just having an inside partner within the tribe. We have our own IRBs to sort of get through. And I know in the past when I've worked with tribes who have their own IRBs, they're very, very, they're huge beasts to get through. And, with good reason, right? And, just protecting, our tribal citizens and their healthcare information, and really trying to, it really requires a good amount of connections and facilitation within the tribe, and having partners that, with whom the tribe has a mutual understanding and a trust already, to be able to facilitate that work among Native communities, instead of coming from the outside in and saying, we want everyone to answer all these questions and do this and that. And, having sort of coming on board and sort of coming in mass is not the way to do it, but really working with those that are already doing the work in the community, or have that in with the community, is really the way to go to help navigate how to best do that research in the community.
Having the intention be clear, but then also having the data come back to the community. The community loves to see that, and then how can we all learn and grow together?
Yeah. I just want to add one more thing to that. I think that as Native communities, we do know the need for a lot of those things, but also it's difficult to just let somebody come in and be like, let us do this for you. Um, and coming in different capacities is really beneficial. So coming in as just offering information on a regular basis to develop those relationships, I think is like a vital step for outside organizations because you can't just come in and be like, we have this great thing. This one time we need this from you. But by them having an established relationship, like they'll be like, they'll have internal people saying, I've worked with these people before. I know they have good intentions, and it moves it forward a lot faster. And that's very needed, I think, when it comes to our Native populations, and working with them.
Thank you, Laura. Kelly, do you have anything on that same topic as we start to close out? What
So I
have
just
been the best experience you've had?
the best experience I've had, just
Experience.
seeing our people get the treatment they need and continue on and continue playing with their grandbabies and seeing them at powwow and all the good things that come from getting through the trenches of treatment. And I did want to just touch a little bit on that medical mistrust, like in a really off-topic way. I've had a lot of patients come in and say, well, I saw real, like mammograms are not good for you. Like you really shouldn't get your mammogram because it's full of radiation and it's going to cause cancer. And just having those conversations with people that, and I'll say, let's watch it together. I want to see what you watched, and taking the time to have those conversations with them because they don't know, and they're trusting what they're seeing on reels on Facebook or Instagram. And so that information that people are getting now these days, some of it's very false and just misleading them. So that's just my plug.
No, and I appreciate you bringing that up because it's important that patients feel comfortable to ask those types of questions, whether in a primary care setting or an oncology setting, or even as they're showing up for, their chemo treatments, that you stop and spend a minute with them and answer the questions. It's, you know, they're going to be, I hate to use the word treatment compliant, but they're going to be more apt to follow through with their treatment and get an understanding of their life ahead than if you just say, oh, that's just out there, disregard, right? Because then you're minimalizing them again, right? They've traveled hours for care, and here you are not even taking 5 minutes to answer their questions. And so I appreciate you bringing that up. Are there any other questions? We have a few minutes. I thank you for completing the poll because that's super important. Anyone? Okay.
I don't have a question, but I just want to express gratitude. So thank you to all four of you for what you shared today and your experiences. I really appreciate it.
Thank you, Emily. All righty. I appreciate everyone coming today. I am truly grateful for Kelly and Laura and Dr. Calderon and Dr. Ananikwam. Thank you so much for coming today. And thank you to all of you that have participated in today's cultural training session. I hope that you've all been given this gift that I feel like I've been getting for the last 8 years, and learning and understanding and knowing how we can be better people in a healthcare setting.
Thanks, Beth.
Thank you all.
Thank you
Miigwech.
all.
Chi miigwech.
Thank
Appreciate it.
you.
Thank you.